it's never too late to embrace new technologies, innovation, and advances in science. Getting stuck to how you've been trained or what you learned 20 years ago may not be the best way to provide best patient care. Best patient care is absorbing day to day new information, new techniques, innovation, and to be up to date to what is the latest that has been proved as evidence-based medicine. Learning is a whole life process. And I want to be honest with you, Ryan. There's very few days in my life where I'm not learning something new.
Do you think it's unique that we normalize this part of our socialization? And I'll share my bias. I don't drink. And I always found it interesting that one of the first things we do in Canadian society, which is fine from a social standpoint, that, hey, do you want a beer once you come in? But if you look like we're doing, it's like I'm handing them a poison just for a social aspect of things with negative consequences.
It's a wonderful question. And I suppose we could be hours discussing, but I feel I have no expertise on this topic. What I have is my personal opinion, which is the substance exists. It is true that they offer you a beer, they don't offer you cocaine. Why? Because there is legislation behind it. Is correct legislation in one side or the other? We can discuss for hours, but why cocaine is treated in one way, heroin in one way, fentanyl in one way, and marijuana in one way, and alcohol in another way? Why there is not a line of substances that affect the body, that affect your conscious decisions? And then we try to homogenize that. There's so many factors that go from social to cultural to business to economics. You've seen quite recently, because of the Trump tariffs, the impact, the economic impact of Canadian stores decided not to sell US alcohol. It's alcohol from one country. And it's a huge, tremendous impact in workload, in business. So that exceeds the perspective of a cardiologist or, as in my case, an investigator in the relationship between alcohol and cardiovascular health. It's more a question that a sociologist or even a philosopher could say, well, the impact of our social and cultural input is equally important than our knowledge and what is good or bad to our body, right? I'm going to the gym every day for the last year. Why did I wait to the age of 58 to do this that has changed my life? Because I had the preconcept that going to the gym, it was a waste of time. There's plenty of evidence saying that that is not the case. Adrian, you're a researcher. You should know way before. Well, but going to the gym is also a social event. You're going to a place where there are other people. You're leaving your house or your family to go and practice sports, or you're deciding to sleep 1 hour less to spend 1 hour in the gym or whatever. But there is a social component. Well, my example tells you that there's never too late to de-articulate what your preconcepts were about something in life. I can't imagine not going for a walk or to the gym once we finish with this conversation.
I'm glad you found that outlet at 58. And it's inspiring when you truly talk to the experts like yourself in an area that say, this is my lane and this is what I know, but otherwise I'm working on opinion, because that truly is the barometer, I believe, that you're talking to an expert, because they know how much it took to be an expert, and everything else, it's like, I'll let someone else answer that. But thank you for that insight. If we go back to what you said about the gender disparities of alcohol consumption and the recommendations of intake, why is females generally 1 drink a day and males are 2 drinks a day?
Okay, so first, what do the guidelines say? Same guidelines that we've been talking about say If we're talking wine, men up to 2 glasses a day, living 2 days free of alcohol a week. Women, 1 glass a day, living 2 days of alcohol free a week. And the question was why? Why, if when we give aspirin, we give ramipril, bisoprolol, rosuvastatin, we don't do gender segregation for each cardiovascular medicine. We give the same doses to men and women to get cardiovascular benefit. Why alcohol is the only substance that we do gender segregation? So I invite you and your audience to Google women and alcohol. We decided to do, the best way to describe it is a sort of archaeological study trying to determine why the latest cardiovascular guideline on alcohol still segregates by gender. So what did we do? We went to the paper, to the document, and we took the references that were cited to support that idea. Every paper, for your general audience, at the end brings a series of previously published papers that are supporting somehow the ideas of this new work. So we found in the guidelines 3 papers that were supporting this idea. So we went to these 3 papers. In paper 1, there was only 1 citation that was the prior guideline 4 or 5 years ago. We went to it. Paper number 2, another 3 citations. And paper number 3, another 3 citations. No one up to that point was telling me why. It was telling me this is part of the truth. So we go to this second generation of papers. What do we find in the guideline? A citation to the prior guideline of 10 years ago. And then we have 2 more papers until we are now in the 60s and 70s, where the data came from. And I'm going, just not to make it too boring for your audience, to tell what were the concepts. Half the dose, because females are petite and smaller than men. Yeah. Well, lots of gender issues have changed in the last 5 years, in the last 10 years, and in the last 20 years. Now we don't consider that the case, and all the rest of the medicines are given in equal doses to men and women. The size of it has nothing to do with the metabolism of the drug. Number 2, liver metabolism, studies conducted in the 60s and 70s. Liver metabolism is a huge advanced topic. Our liver experts at Queen's, and I'm thinking Dr. Fleming, for example, are spectacular with the latest of the latest. Medicines are not qualified for different liver metabolism between gender. There may be specific differences that do not affect metabolism of substances. 3, listen carefully. Women get drunk much more easily than men. That is purely gender discrimination. It's given to the gender the characteristic of how soon or at what doses you get drunk. What? That is completely unacceptable these days. These are the 3 major issues of why the current guidelines are classifying men and women differently. So our expectation is that this publication, the next guidelines, are going to remove the differences and to say 2 glasses are this and 1 glass is that, but not impacted by gender. Or if it's going to be impacted by gender, with a 2025, a 2024, 23 study that is going to show that currently, with the social changes around the, I couldn't say the Occidental world, maybe around the planet, on acceptance of equity of gender, these preconcepts are going to disappear. And as you were suggesting at the beginning of the presentation, social history not impacting our medical decisions. Of course, today you want to keep saying that it is in the guideline. Well, guidelines are just guidelines, are not mandatory things that you cannot think about or you cannot challenge. Right? So we decided to challenge the guideline and to say we do not find any substantial acceptable physiopathological explanation to segregate alcohol intake by gender when the outcome is cardiovascular outcomes. Why? Because no other substance has gone through that requirement.
If I hear you correctly, that the evidence for that is decades old, it's not rigorous, and it has no pathological rationale to actually substantiate it. I'm just thinking, how come it took so long for somebody to actually think it's like, is there any objective data that corroborates any of these guidelines? Because yeah, like once you said it, like that's the only kind of substance we segregate, like men versus women for this. So that's so interesting.
Ryan, I'm going to use a personal experience on how things can dramatically change and how much time takes construction and deconstruction of knowledge. When I was a resident, you can calculate, I'm 58, I was 24, 25, still in residency, 30 years ago. A man with chest pain was a myocardial infarction, a heart attack. A woman with chest pain was a hysterical reaction. The man will get the ECG and troponins. The woman, you're fine, you're fine, you're fine. In the last 30 years, we learned that men or women with chest pain require exactly the same type of care that cardiovascular disease in a woman presents with the same physiopathology, incidence, and characteristics that men, that then specific issues have some gender differences. But a woman with chest pain is cardiovascular until you prove otherwise. And if you're going to say that that is not cardiovascular, you have to follow a sequence of studies that will determine that things. Good luck. This is not cardiovascular. And that applies equally for men and women. And now, when I was a resident, you enter the CSU, 98% were male. Now you go to the CSU and it's 60-40, 55-45, 50-50. Why? Because there's no more gender discrimination. And the new generations, when they hear this, say, what? Hysterical reaction, but why? It's completely irrational, right? Construction of knowledge, of new knowledge, Ryan, takes an average of 2 to 3 years. The idea, the design, the study, the application, the results, moving into practice. Depending on the topic, 3 to 5 years, construction of knowledge. Deconstruction of wrong knowledge takes 2 to 3 decades. We have to deconstruct the idea that women were having less heart attacks when they were having chest pain. Today is worldwide accepted. However, you will see 20-25 papers where male were treated for coronary artery disease 67% of the times, 72% of the times. There's still a predominance. And part of that may be that we're missing the right diagnosis in women.
So why is that?
So, so cultural change, new deconstruction of knowledge to arrive to reconstruction. Remember that to reconstruct, first you have to deconstruct knowledge. I know that you're very interested in having an interview with me around cardiac devices. All right. For some patients that we implant a defibrillator that comes from mid 90s studies with 180 patients included. Mid 90s. In 2023, those studies were repeated and there were no benefit. Ask me, if I stop implanting those defibrillators in patients with the characteristics named in the 2023 study. Deconstruction of knowledge takes 2 to 3 decades. So the best that we can do for the new generations is when we're constructing knowledge is to follow steps that are going to arrive to right knowledge so they don't need to go under deconstruction in the future. AI is in my specialty is one of the areas where we have two options. We do the best possible AI, or we do AI and we are going to get stuck in the same problems that we have today with the AI developed 20 to 30 years ago. For example, remember, this affects you completely. When you go and see a patient and you do an ECG, there is an automatic diagnosis, right? That you read in the ECG. That is done by AI. How the machine knows what the patient has. It was fed with an AI system developed 30 years ago. And we both know that that report has very poor sensitivity, less than 60%. So you have to read it yourself and do your interpretation, and sometimes it's going to be different than what is written in the paper of the ECG. Okay, if we develop an AI system that has the same mistakes that this one, we're going to arrive to the same results. But we have the opportunity through machine learning to do it way better. So the concept of construction and deconstruction is now we know how tough it is to deconstruct knowledge in medicine. So please, let's follow every single step to construct knowledge so the new things we learn are going to stay forever. Because if we start applying it in 3 to 5 years, and then we have to stop applying it because we realize that more information came and what we initially thought it was all wrong, it will take 2 to 3 decades to deconstruct that.
So, correct me if I'm wrong, because this is so interesting, and Queens is doing amazing work and getting knowledge out there about AI in medicine and how it can help amplify our practices. So if we use AI correctly, it can help deconstruct knowledge quicker, but also prevent us from going down that place in the first place, because we have our blind spots. We're fallible as humans, but as AI, it can help pivot us to say, hey, these are your blind spots. This is the best empirical data, and this is the road not to go down for you to follow this cognitive bias you're currently ensuing.
Anecdote. I know that you like this. I was supervising a presentation last year in London, UK, of researchers about electrocardiology about around the world. And there was an amazing group, I don't want to identify them, there's no need, that presented an ECG AI model that was fed with 2.5 million cases. I said, whoa. You said 2.5 million cases, right? Yeah. This is when I take over. And who were the experts? How were selected the experts that provided the 2.5 million cases in order for you to construct machine learning? And the young investigator, he's looking into the public to his mentors, and he replies to me, no, these 2.5 million cases were fed from automatic analysis of the ECG machines that correspond to this and this brand. I said, you fed a new AI ECG reading system with a system that has less than 60% accuracy on the diagnosis? Yes. Okay. Next question from the audience. Once we finished, a group of 5 people from this group comes to talk to me and said to me, Adrian, we never thought about it. We took those diagnoses as correct diagnosis. All right, guys. Life is long. The model is good. Maybe the way to fit the machine is different. And currently there are work done by Swedish investigators led by Dr. Linda Johnson that did exactly this. They fed with millions of cases supervised by an international group of leaders in ECG that are 100% trustable. So then the results of that AI is what I want to see. Because if you feed the patient or the machine with the inappropriate food or inappropriate information, the outcome is not going to be good.
I have to be mindful of your time, and I can't wait for you to come back. But the last question is, if you could do your whole career again in the AI generation where it's highly sensitive and highly specific, would you love to work in that world?
What a question. The point is, if I have to do my career again at the age of 58 or at the age of 32. At the age of 32, I embraced new technologies in electrophysiology. The things that were done were the first time to be done. And when I moved from Argentina to Spain and I decided to interrupt my training in Spain to come to Canada, is because Canada was offering me technology that was not available in Latin America or Spain. And I do remember my first case, I was already an electrophysiologist when I redid my training in Canada using a machine that I have only seen in screens or books, but I have never tried myself. My first case in Canada with headphones, so I was able to communicate with the people on the other side of the wall. And to me, it was innovation in technology. So I could answer your question saying, if I have to start it again at the age of 35, I could embrace new technologies as part of my training from day zero and then see where that technology takes us. If I have to restart my career at the age of 58, I will bring to my team of teachers people that already knows how to do these things. So I don't have to learn to do it. But beyond the joke, I think that it's never too late to embrace new technologies, innovation, and advances in science. Getting stuck to how you've been trained or what you learned 20 years ago may not be the best way to provide best patient care. Best patient care is absorbing day to day new information, new techniques, innovation, and to be up to date to what is the latest that has been proved as evidence-based medicine. Learning is a whole life process. And I want to be honest with you, Ryan. There's very few days in my life where I'm not learning something new. And this can be discussable with my colleagues, but that's my approach. And I can learn not only from the big teachers, I can learn many different aspects of science and life from the admins, the secretaries, the people cleaning the healthcare space, the hospitals, from people that is not necessarily involved in science, right? It's an attitude. I hope that I don't have to have a chat with you for the day that I decided to stop learning.
Thank you so much, Dr. Baranchuk. It's incredible to see your authentic passion for these topics, your humility, and disseminating out this knowledge and all this incredible wisdom that I hope will shape the listener's career. I know it's already shaping mine. I've had so many light bulb moments, and please come back anytime. I know we can go deep and hours into each and every one of these topics. So thank you again.
Super happy with this interview and very happy to return upon your request.